All right, so good morning. Thank you, Laura, for inviting me here. So I'm Amber Caronto-Leach from the East Texas Task Program, and today I'm going to provide a brief overview on some eating disorders and the intersection between eating disorders and trauma, talk about some treatment considerations, and when we need to look at referring our clients on for different levels of services. So here's our learning objectives for today. We're going to recognize different types of eating disorders, again, describing the intersection between trauma and the development of eating disorders, summarize our treatment considerations, and determine when to move a client to a higher level of care. So objective 1. So there are 6 primary types of eating disorders that we look at in the current DSM-5. The 3 we're going to focus on today is going to be anorexia nervosa, bulimia nervosa, binge eating disorder, the other thing being pica rumination disorder and avoidant or restrictive food intake disorder. I'm not going to focus on those 3 as much today, just for the sake of time. We're going to just focus on the 3 primary ones. So what do you picture when you think of anorexia? Usually we think of a really skinny girl. She wants to be thinner than she is. She may even be like skin and bones. We have that picture of, ribs showing and things like that. Typically we do think of females. However, we are seeing a lot more males with anorexic behaviors. Anorexia often starts as a regular dieting and often transitions into the extreme weight loss with the eating disorder. It can start with some external feedback. So people starting to say, hey, you're looking really good. You're so skinny. I wish I looked like you. So getting that feedback from others with this expectation of how people are supposed to look. Well, we're getting into a time where we're a lot more aware and accepting of different types of body image. A lot of our models and even what our Instagram and social media influencers show is still that kind of Twiggy-esque body image. The really thin body image, really fit, is what's often portrayed out there. And when I think about eating disorders, I always think about a cover on a magazine years and years and years ago when Britney Spears was all over the place. So back in probably the 90s. And it had a side-by-side picture of her. And on one side it said, then skinny and happy. And on the other half it said, now fat and sad. Only she wasn't fat. She just wasn't like super thin at this point. I think it may have been even after she had her first child. And that visual has stayed with me of this way that, people view themselves, of how we, look at ourselves or what's portrayed out there for our youth. While societal attitudes definitely plays a part in eating disorders such as anorexia, the family influences are there as well. What is the family's view on weight? What is the family's view on food and on eating? Even genetics and brain chemical imbalances, as well as developmental issues, can all impact the development of this disorder. When a child under 12 has anorexia, there's usually a family history of weight problems, a physical illness, or a mental illness such as depression or a substance use, whether or not it's even within the child, but just within the family. That tends to be a kind of some of the family structures around early childhood eating disorders. A big problem with this is the lack of calories can lead to additional emotional symptoms, such as the irritability or the moodiness, even strange food obsessions. They may become obsessed with making their own food or become socially withdrawn. They'll have the physical symptoms such as being really, on top of being really thin, having dry skin, dehydration, constipation, lethargy, dizziness, even sensitivity to cold or fatigue can be symptoms that we see in these young people. It's especially dangerous when it starts to impact the development of the bones and the muscles. In children and in our teens, our adolescents, they need to be growing. They need that nutrient for their bones to grow, for their muscles to grow, for their brains to grow. So it can get really dangerous because of not being able to allow their body to thrive the way that it needs to due to the restriction of calories, impacting that restriction of nutrients. So looking at our anorexia kind of symptoms, like how does this look different than some of the other disorders? The big one that we know about is the failure to gain or sustain that expected weight for the person's age, or if it's a young person, failure to gain the weight that's expected for their age group. And so they're not really reaching the size that would be expected. Their growth isn't what would be expected for someone of their age. This distorted self-image. So there are some people who are super tiny. My sister has always been really thin, really petite. Just doesn't carry a lot of fat on her body, doesn't carry a lot of weight. But it's just simply is her physiology. It doesn't have to do with this distorted self-image. She doesn't believe negatively about herself, and that, like, there's no restriction of calories. And so just because someone's thin doesn't mean they necessarily have an eating disorder. So it's got that distorted self-image piece in it as well. There is the restricting type, what we typically think about with anorexia, and then the binge eating purging type, similar to bulimia, only this one actually has the weight loss with it, whereas bulimia doesn't. So with bulimia nervosa, the average age of onset for this is actually 16 to 17 years of age. It's starting to creep into the younger ages, but that's still more the exception than the rule right now. So if you think about why this would be, why would we start having the binging and purging about 16 to 17? If we think about it, even though we have our young ladies developing, as early as 11 or 12, this is really when the body starts changing for reproduction. So the hips are getting larger. They don't have the kind of early teen type flat stomach shape anymore, just because of physiology growing. So that can start creating this concern of, oh no, I'm putting on weight. I need to be looking a certain way. When we're looking at bulimia, the big key for it is that purging behavior. Now, purging is typically thought of as vomiting. And the concerns with this is that the body can become conditioned to vomit after eating. So once they have this behavior for a while, sometimes they don't even have to force themselves to throw up. Their body just simply won't hold the food in its stomach. And so they'll eat something and their body is so used to throwing up that they'll immediately just throw it right back up. And then they get to the point where they're like, I can't help it. It's not me. It's just my body at this point. So the binge starts kind of controlling them at that point. Other ways that they may binge, though, is fasting, such as going on a juice fast or like a cabbage soup fast, or one of the latest trends on how to drop weight quickly. They might use laxatives or other excessive methods to clear the bowels, or they might do excessive exercising to burn off calories. This is something that I often would see in guys with eating disorders, is that they would seem to be eating normally, but they might spend 4 or 5 hours in the gym. Spend a couple hours in the morning, spend another hour at lunchtime, spend a couple hours after work to be able to maintain that physique. So it's really that excessive exercising because of that overly conscious about their physical body and how they look. The compensatory behaviors to prevent weight gain is those binging behaviors at least once a week for 3 months. Skip the wrong one. It's not always associated with views of body shape and weight. And this doesn't have the weight loss with it like anorexia does. So it's not like they're having the extreme weight loss. And the binging is not exclusively associated with anorexia. If there's the weight loss and the other symptoms similar to anorexia, then we're going to diagnose that instead of bulimia. And then we have binge eating disorder. So this is a newer one. So it's basically bulimia without the purge. There's a lack of control over the eating. They may not want to eat what they're eating. They may recognize they're full, but they just can't seem to stop it. They may recognize they're not hungry, but they don't really seem to have control over what they're consuming. So it might be somebody where they get a package of cookies or they get a bag of chips and they find that they're eating the whole bag, not just a portion of it. But they once they start, they just can't seem to stop it. They don't have the purge behaviors, which can often lead to weight gain and really a lot of depression and shame associated with this eating behavior. So I'm going to use examples of a past client of mine, and I do have permission from her to use her as an example for training purposes. And she was actually an older woman who had dealt with weight for all of her life. And the binge eating disorder was a big one for her. Whenever she got stressed, whenever she got emotional, she would find herself eating. And she wouldn't even want to eat, but she would stop by like Brahms and get a hamburger and fries and get a milkshake. And then she would go and stop by somewhere else on her way home and get like a package of Hostess cupcakes or some sort of sweet cakes, and eat all of those while she was driving home. And so she would consume all of these calories in a really short period of time, and feeling like she had no control over this type of behavior. Like once she started eating, it was really all in her body. And no matter how many times she said, I'm not stopping to get something to eat on the way home, she would find herself stopping. A lot of times these people eat alone because they're really embarrassed and shamed about how much they're consuming, and they feel disgust about themselves related to the behavior. They may hide the food packaging. And so if they're living around people, they hide how much food that they're eating by putting the packaging in the bottom of the trash can or hiding the packages in their rooms. And so looking at the intersection between trauma and the eating disorder. So we have our three main eating disorders, the anorexia, the bulimia, and the binge eating disorder. And we have their eating disorders without trauma and trauma without eating disorders. And you're going to hear me say this several times through the presentation. So we are looking at specifically that interaction between the two today, of that overlap between eating disorders and trauma. Rodriguez and his team, in a study completed in 2005, looked at about 50% of those with eating disorders have some sort of trauma history, whether a child, sexual abuse, verbal abuse, domestic violence, emotional abuse, that there's some sort of trauma in about 50% of the cases with eating disorders. And so here's our reminder. Like I said, you'll hear me say it quite a few times through the rest of this presentation. There's eating disorders without the trauma, and there's trauma without the eating disorders, but we're looking specifically at that interaction between the two. So what happens in trauma that may lead to the eating disorder being one of the symptoms of it? So Malecki and their team published in 2018, and I'll cite this article quite a few times through this, and I have a resource page at the end if you want to look at these articles yourself. That really looked into the impact of kind of this intersection, the impact of trauma on those with eating disorders, and the impact of the eating disorder, what happens within the eating disorder when there is a trauma background. And they looked at how this repeated violation of the body, such as in child sexual abuse, can lead to the dissociation of what is self. Kind of that loss of who am I? What is my body? What do I need to take care of within this body? That concept of body as self becomes this distant thought. So again, especially when there's that repeated child sexual abuse, that sense of self, that sense of who I am and what I'm responsible for gets lost in the process of this dissociation. The awareness of what body needs, what this body needs, becomes separate from awareness. And so looking at how if a person is dissociated from their body out of necessity for survival, are they able to recognize when they are hungry? Are they able to recognize when they are full? I call this the head being disconnected from the body. So the person's cognitive, they're aware that they have the body, but they really can't feel into themselves because of the level of trauma that's happened. And I love this quote, that the body becomes a battleground, not a place of safety. And so when we're wanting to take care of somebody or something that's important to us, we want to make sure that they have the best, right? We want to make sure that they're eating well. We want to make sure they're taken care of. But what if something's happened to you where your body is not something that you love or enjoy or even want to be in or around, and it becomes almost like an enemy rather than something you'd want to take care of? When a person's raped or otherwise physically violated, they can be disconnected from their body. We talk about dissociation when it comes to trauma, and this is necessary. This is necessary for survival, especially in our children and adolescents, and especially when it happens by someone, the abuse happens by someone who's supposed to be a support or a safety net for them. It's healthy in the moment. The separation then becomes an ongoing separation where the person may feel disdain for their body. They may feel angry at it. They may feel they deserve to hurt or that they deserve to not be pretty, depending on what the disorder is. It's not uncommon for obesity to be used as a protection, so people don't notice them, or they're not seen as attractive to the opposite sex. I had my prior client I talk about tell me once that after losing 80 pounds, people would see her again. She would be seen in the stores. She was no longer being ignored as she walked through the aisles. And that in and of itself created anxiety for her. Just the fact that people saw her as human again after she had had that weight loss. That she was having to learn how to be seen in the world and how being seen was okay and was safe, and that as an adult, she was able to be seen and could protect herself. She's one who also talked a lot about her body being a place of pain or betrayal. She talked about how she saw her body as the enemy and as herself kind of a victim to her body. And so in some ways, she didn't think her body deserved to be taken care of because it was this other entity that would cause her pain. For these individuals, this concept of self may become more focused towards what the other wants. In order to be pretty or to be thin or to be feminine is to embody not what the person themselves feels like they need to be, but what they're supposed to be according to their abuser. So eating becomes a way of taking back control. When there have been the multiple violations to the body or excessive control in a person's life, whether or not to eat can be something that they are able to control. The bodies and brains are meant to respond to food. Eating lights up our reward systems, and this feels good. We like having those reward systems light up. Think about eating one of your favorite foods and how it feels in your body to eat one of your favorite foods. One of mine is I love a good creme brulee, and I will sit there and eat it slowly because I enjoy the reward center from it. I enjoy the reward that I get from eating something that is really just pleasurable to me. So food is supposed to light up these reward centers. That's how we're made. But many times we start eating when we're bored or when we're avoiding something we don't want to do. Eating can become a distraction when we're not really wanting to think. And so we have these two sides, one with anorexia, where food becomes something to control, and the other side with our binge eating disorders and our bulimia, where food becomes this comfort. It becomes this place of safety. It becomes something that can light up those reward centers. When there's a tendency towards a need to control, such as what we would think about in some of like the OCD type behaviors, then obsessive eating can become a stress relief. So having a regimented eating plan can become a way for them to control their life and feel in control when things otherwise are not able to be managed. So controlling their food, controlling what they eat, being on a strict diet or nutritional plan allows that sense of control. And again, that societal feedback when they're in control. Oh, I would never be able to eat like you do. How is it that you're sitting there eating a salad whenever the rest of us are eating pizza? You have so much control. So there can be this societal feedback that happens and feeds into that sense of this is what I'm supposed to be doing. Although binging and purging have garnered more attention with regard to kind of the emotional mechanisms, it's really able to be applied in either other types of eating disorders, including restriction. So again, looking at that investing of time and energy into the rigid eating rules. And the over-evaluation of weight and shape, helping to distract from other distressing emotions. You know, I can't help feeling depressed in these ways. I can't fix that, but I can control my life in these other types of ways. And then looking at that trust piece. It's all about that trust. Can they trust themselves? Can they trust you as a provider? Can they trust their own body? When a person's been violated, there's a loss of trust in themselves and those around them. Again, especially if that's someone who violated them was supposed to be a person who was going to protect them. We have children who are abused by parents, step-parents, family members. We have young people or adolescents being raped by the boyfriend or someone that they thought was a best friend that was just hanging out. And so they have this concept of like, am I able to trust this person? Am I able to trust people who say they're here to help me? They may have an innate distrust in you as a provider, especially if you're attempting to take away their one thing that they can control in their life. If they feel like their eating habits or their ability to look a certain way or their ability to keep that weight on so they can protect themselves, if they feel that you're trying to remove that and they don't have other tools to protect themselves or to manage those feelings, they might see you as a threat because they see you as taking away these coping skills. And if they don't have the other ones to replace it, what are they going to do? You might end up being seen as untrustworthy because of. And can they trust themselves? Are they able to trust when their body's hungry or when it's not hungry? Are they able to trust what their body really wants? Are they able to understand what is good and what is bad? When they eat one thing, do they feel good about it? When they eat another thing, do they feel bad about it? Do they even recognize that? Especially when sexual abuse or rape has led to orgasm or something else that's supposed to be pleasurable because, again, that's how our bodies are made, then the point of view of what is good and what is bad can get really messy. They learn that they can't really trust what good or bad is supposed to be. And can they trust themselves to know how to respond appropriately? If they've been choosing behaviors for survival and they're surviving, they've made it this long, and we take away that survival, do they trust themselves of how to manage without this? If we're trying to get them to come back into their bodies and to not be dissociating as much, do they trust themselves to be present in their bodies? Do they have those skills? Do they know how to determine if what they're choosing is safe or unsafe? I want to look at some treatment considerations as far as treating those with eating disorders who have a trauma history. Some things that we need to look at is accepting the need to eat for those who are in that anorexic nervosa disorder. And I like the difference between diet and nutrition. So one thing I like to point out is that a Snickers bar and an avocado have just about the same number of calories. There's just about 15 to 20 calories difference depending on the size of the avocado. However, there is a vast nutritional difference between the two of those as far as healthy fats go, as far as number of sugars, as far as how our bodies respond to them. Similar calories, different nutritional makeup. And so, finding the need to eat and the need to consume foods that are nutrient dense and that are going to provide their bodies with what they need to be able to think clearly and have the energy to take care of themselves. I had a young person I worked with who was a binge eater. So she would eat a lot of pasta at night, but was continuing to gain weight because that's all she ate during the day. She drank water all during the day and then would binge on a big bowl of pasta at night. Once we were able to get her to eat regularly balanced meals throughout the day, she went from being, and she was getting to the point of being obese. It was becoming very unhealthy on top of nutritionally it wasn't balanced. Once she was eating those regular nutrition balanced meals, her body became the weight that it needed to be. She didn't only lose weight, but her proportions changed a bit. And so she started putting on muscle and she started having energy to go out and get more movement in her day rather than just feeling the need to sleep all day. She had the mental energy to be able to complete her schoolwork, so her grades went up. And so it wasn't just about getting the calories in, because she was getting her calories in, but it was the makeup of those calories that made the difference. We want to work on changing their relationship with food. Rather than seeing it as an enemy, we want them to see it as something that really support their bodies to be able to reach their goals. Helping to create that cognitive dissonance between eating habits and goals. What do they want to do with their life? What do they want to be in their life? What are those goals? And how does having a healthy relationship with food help to reach these goals? How is what they're doing now not helping them to reach those goals? We really want to work with them to collaborate on creating this treatment plan. So it's really working together, building that relationship to create that trust, that you're not there to just take away their coping skills they've been using to manage this trauma, but you're here to help them really heal from that trauma in a different way. We want to not only look at the symptoms and behaviors, but really look at what are those psychological drivers that are behind all of this. And so I like to give the example of in my garden in Central Texas, I have these little clovers that come up. They're just about 2 or 3 inches above the ground. They're not very big. They're really easy to grab hold of and pull. The problem is if you just take care of what's on the surface or even what's just below the surface, they're just going to keep coming back up. So you have to follow their roots all the way down to get to the little bulb that is sometimes 5 or 6 feet away from the top of the plant that we're seeing. So those are what we're looking for. What is it that's driving these symptoms of an eating disorder? What is it that's driving these behaviors of an eating disorder? What is this particular behavior trying to solve? And how can we help them to solve that problem, not just looking at what's on the surface? They also need a support system. This is where we're really looking at this biopsychosocial viewpoint of healing. It's their body, it's their psychology, and it's their support system. Do they have good friends in place who are going to support them? Do they have a family in place that's going to support them? Some families talk down about weight. They say negative things to kids as young as 6 or 7 about what they're eating and how they're consuming food, without teaching what else to do, without teaching healthy habits. They just talk about the bad ones. And so do they have a good support system, especially with children and adolescents? Do their families understand the disorder? Do they understand the root of it coming from the trauma? And do they understand the support that their child needs? Weight checking. As much as we tell our clients, don't check your weight at home, we want to be checking it in the office. We want to be seeing, is there a positive change happening? And positive change being, are they getting to a healthy weight for their age and their size, like their height? So is someone who is healing from anorexia, are they gaining weight in a healthy way? For people who have binge eating disorders, are they losing weight in a healthy way? Collaboration with other professionals is really important. So being able to connect them with a registered dietitian who does have education in eating disorders, working, from the mental health side, from the physical health side, and having permissions for all of the professionals to work together to make sure that we're really surrounding this client with support to make positive moves. Other things to look at is that strong therapeutic alliance. We want them to have a reason to keep coming back. Because we're really working on a hard area and trying to uproot this, sometimes a really in-depth coping skill, we want to have that relationship with them. And we want to emphasize that the healing is from the trauma. It's not just about the eating disorder, but we want to work with the trauma and then the symptom of the eating disorder. We want to reduce dropout rates and reduce relapse rates. The strong therapeutic alliance and helping them heal from trauma helps with that. Those with eating disorders who also have a history of trauma do tend to have poor treatment outcomes if the trauma is not addressed. And within trauma, it tends to increase the severity of the eating disorder symptoms. We want to also promote the client agency. We want them to have control in healthy ways. How is it that we can give them pieces of their life back where the eating disorder and the trauma may have felt like it took away the control? How can we give them choices that are going to lead to healthy decisions? Some provider considerations. So there tends to be an increase in provider countertransference when an eating disordered client also has had trauma. So that means we get pulled into the story a little bit more with these clients because it's not just the eating disorder, but it's also dealing with that trauma history. And so being aware of how we might be getting involved with the client. How is our involvement when we're working with these individuals? Are we getting over involved with them? Are we finding ourselves emotionally separating from them? What is our interaction with them? A lot of these clients, because of the relapse rates, have been through provider after provider after provider, and they've had a lot of people give up on them. So we want to be able to support them and encourage them and provide them the services they need, recognizing they are going to have to make their own decisions. What is our expectation of them? In the stages of change theory, relapse is a piece of it. That if they're in contemplation and they move into that preparation and into the action stage, then they may be in action for a while and something stressful happens and they go back into that relapse. They may not recognize they're going back into that relapse. So we want to be able to look at what is our expectation for the healing for these clients? And what is our experience with them? What do you know about working with individuals with trauma? And what do you know about working with individuals with eating disorders? And where can you find more information and learn more about it? Some client considerations. Interpersonal trauma exposure is predictive of more complex clinical presentations. We tend to have worse symptoms, with the trauma being layered on top of the eating disorder. Trauma is more of a risk factor for binge eating connected disorders than those which are not binge eating related. And think again about how when a person's body's been violated, they want to create that protective barrier around them. And being overweight creates a protective barrier. A physical barrier, a visual barrier sometimes, an emotional barrier, that instead of them being seen as a sexual icon or a sexual being, they're seen as the fat person. They're seen as their weight. They're seen as what that looks like instead of being seen as who they are. So it becomes protection. If an event can produce PTSD, partial PTSD, or clinical anxiety, then it may increase the probability of developing an eating disorder. Just because someone had a trauma disorder or had trauma does not mean necessarily that they'll have an eating disorder. Remember, eating disorders can happen without trauma, and trauma can happen without eating disorders, but there is an increase of the probability of it. We want to look specifically at some of the information out there with eating disorders and men. So adverse familial relationships, specifically with physical abuse and emotional abuse from fathers, does tend to increase the risk of eating disorders in men. And men with childhood sexual abuse history are more likely to use laxatives or excess working out as their purging behaviors when it comes to bulimia. So how do you know when to refer and who to refer to? Understanding what is your scope. Again, I've asked these questions before, but what is your experience in treating trauma disorders? What do you know about dealing with trauma? What is your experience in treating eating disorders? And what's your experience in treating them together? Who do you have to contact for consultation and supervision? Who can you talk to? Do you have the skills to be able to work with the other professionals that are needed for this client? And do you have the ability to consult with people who can help support you if you do have the foundational skills? In choosing a referral for these clients, we want to look at, are they eating disorder only, or do they also address that trauma piece? Some clinicians are very, very good with eating disorders, and some registered dietitians are very, very good with eating disorders. But not all of them have that trauma-informed viewpoint is coming to eating disorders. So we want to make sure that for these particular clients, not only do they have experience with eating disorders, they also have experience with treating trauma. And what treatments do they use to address trauma? Are they evidence-based treatments? Is this something they treat on occasion? It's on their Psychology Today profile. Or is this a regular population of theirs? Is this something they actually specialize in? This is what they do on a daily basis. Do they have additional certifications that show that they have additional trainings and are legitimate in what they know about eating disorders? Does the client need a higher level of care than just an outpatient? Do they need an inpatient setting or some sort of rehab facility? Has it gotten dangerous to the point that they're not able to control this on their own and they need that level of support? Registered dietitians can have experience with eating disorders, and we want registered dietitians who also work with mental health practitioners and other professionals. So not ones that work solo, but ones that are able to work in that collaborative community. So specifically locally, we have Celeste Smith, who's a LMFT and is at Celeste Smith Counseling. Working with eating disorders is what she does. She also has the trauma background. And then Sarah Upson at My Signature Nutrition is a registered dietitian who does work with eating disorders as well. So we do have a couple really good resources in our area. So in conclusion, people can have eating disorders without trauma and trauma without eating disorders. I want to make sure that that's in there. Trauma involvement creates an additional component which must be addressed for total healing to take place. If we keep just looking at the symptoms of what we see on the surface and don't deal with what's rooted underneath, the plant's just going to keep coming back up. The symptom's going to keep coming back up. Whether it's the same or different, it's going to keep coming back up until that trauma is dealt with. We need to treat the roots, not just the symptoms, and know when you're out of scope and be willing to ask for support and refer when needed. We can't be experts on everything, but we can find out who is out there who we're able to refer to make sure we're giving our clients the best opportunities. So there is my list of references, and I can send this slide or this presentation to Laura to send out if you guys would like it. And then my information here at UT Health.
Thank you, Amber.
All right. Any questions or discussion?
So we do have a question from Sonia. How do you best assess weight gain or loss when the patients refuse getting on a scale or using measurement tools? And is it acceptable to focus on health and correlated BMI rather than weight in pounds? Amber, you're on mute.
I am. My computer is telling me that. I do like to focus on the more of the general health. You know, how was the sleeping? How was the eating? How was the energy? Things like that to me are a way of looking at kind of that health piece, even more so than the BMI, because I know some people who work out a lot, and so they appear to be very small, but they may weigh in to where it makes it look like their BMI is a lot higher, but really they're just solid muscle. And so I really like to look at the health and the size and how to do the measurements. I think that just needs to be part of the treatment plan. They don't have to know what their numbers are. If they don't want them, you know, they can close their eyes when they hop on that scale. But that being part of, like, we really need you to do this so we can make sure that you're getting healthier. Did I answer both of the questions?
I believe so. The second part was acceptable to focus on the health and correlated BMI rather than the pounds. So I think so.
Yeah,
other
I like
questions.
Yeah.
Thank you, Ms. Carontalich, for the presentation. It was very insightful. I do have a question. Michael Watkins, two here at UT Health East Texas. I have a question about a dialogue around the relapse periods. You know, obviously we don't want to be, you know, kind of come down on the person, but I think being overly concerned about it, I think could present some problems as well. So is there a certain approach that you recommend for handling those periods of relapse?
The first thing, and I'm sure that you guys do this, is I like to educate on the stages of change. Like, all of us are in stages of change in something in our life. And so it's something we all go through when we're trying to develop a new habit. And so being able to help them understand the stages of change and where they are within those stages. So when the relapse happens, taking it as okay, we have information. We understand where there was a kind of a hole in what we needed in our support system, and that's okay. Let's just go back and rethink this. And so I think about, like, the tools that we provide them for processing the trauma and for managing the symptoms of that trauma, which in this case is the eating disorder. It's like tools in a toolbox. And so they may know how to fix their plumbing, and they may know what to do about a leaky roof, but then all of a sudden they have an electrical surge and they don't have the tool for that. So we look at those, you know, what happened in that stage of change, where we are we back to contemplation? Are we back to contemplation? and looking at even doing a chain analysis. Okay, what started this? What happened before we had this relapse of behavior? Okay, well, you know, your friend told you that they didn't like you anymore, or someone gave you a look at, you know, when you were at the mall. And so being able to go back and say, okay, where was that weakness? That's okay. Now we recognize it's there. Now we can do something about it. Let's just build it back up and keep working through.
Very nice. Thank you very much.
Welcome.
Other questions? We really appreciate the interactive kind of opportunity here. All right, Amber, I'm thinking that we don't have any other questions at this time. So I'm going to thank Amber again, and I'm going to go ahead and take the screen.
Okay.
And provide a little bit of information about the Child Psychiatry Access Network. So let me go ahead and take over the screen. Thank you. All right. Are we able to see my main slide there, Amber?
Yes.
Okay, great. Thank you for. All right, so good afternoon, everyone. And again, thank you very much for joining today's Cpan Continuing Education presentation by Amber. My name again is Laura Young, and I'm the Senior Program Manager for the Northeast region of the Texas Child Psychiatry Access Network, also known as Cpan. I'd like to just share for a couple of minutes here at the end about our program, who we are, why we're here, and what we're doing, and how we are there to support PCPs across our region of 25 counties. So just a little bit of a backstory. In 2019, the Texas legislature approached its 86th regular legislative session. And with the increasing rates of childhood depression and anxiety, as well as skyrocketing suicide rates, and of course, devastating school shootings, the mental health of children was really on the mind of Texas legislators. They knew there was a problem facing our children and they wanted to do something about it. And so through a couple of Senate bills, they did so. So Texas Cpan was born out of Senate Bill 10 initially, which was introduced by Senator Jane Nelson, who you may be familiar with that name. She's the chair of the House Finance Committee. And she introduced that in March of 2019, which was way before we had COVID start. As the bill moved through the House, the provision for services and the funding was added to Senate Bill 11, which was then passed in May of 2019. So that's when really the support services were born. So that Senate Bill 11 provided the funding and the guidance to create what we call the Texas Child Healthcare Consortium. This collaboration of state health-related institutions, state agencies, and nonprofits were really focused on one thing. And that one thing they are focused on is supporting evidence-based initiatives that directly and positively impact the mental health of children and adolescents in Texas. Cpan is one of those 4 initiatives. So a network of 12 regional academic hubs was developed for Texas Cpan through what are called health-related institutions. So those health-related institutions, or HRIs, provide telemedicine-based psychiatric consultation, care coordination, and continuing education, such as today's event, to PCPs across their regions. So we cover, as far as Texas Cpan, all 254 Texas counties, and your UT Health Science Center hub covers the 25 Northeast Texas counties. You have Northeast Texas folks covering Northeast Texas folks. Cpan psychiatrists, we have 3 of them, assist providers with identification and treatment recommendations for mental health issues using a biopsychosocial approach, which is what children and adolescents need. This support aids PCPs in meeting mild to moderate mental health needs right within their practice. When additional mental health resources outside the PCP clinics are needed, our Cpan staff have an extensive database of validated mental health resources they have built from across our region that are available for PCPs and their clinic and referral staff. These services from Cpan are all funded by the state of Texas, so there is no cost to the provider, clinic, patient, or health plan. It's all covered by the state of Texas. So we do have, this is the team that serves here at UT Health Science Center. We have 3 child psychiatrists, which you will see here. They are all child psychiatrists, but also we have Dr. Taya Johnson, who is also a forensic psychiatrist, and Dr. Catherine Kerr is also a pediatrician. We have a pretty great team here. The team that provides resources and referrals and works with non-pharmacologic needs are both Elizabeth Hooker and Wiley Martin. Those are our what we call our mental health specialists here and our behavioral health specialists, and they are the individuals. When you call as a PCP, they will be who answers the phone. And then I am the person that handles the program operations. So with Cpan, we have 3 distinct supportive services that support the needs of young patients, the PCP supporting the young patients with behavioral health needs. So we have real-time psychiatric telephone consultation that is available to discuss medication management or complex cases. Real-time consultation for non-medication related needs such as behavioral health planning, safety plans, assessments, screenings, and such. And then finally, care coordination services, which I mentioned earlier, which assist with identifying referrals and resources that you can share with your patient and your patient's families. We're servicing specifically your PCPs so that PCPs can serve their families and patients. Enrolled providers or registered providers with Cpan can call back as many times as desired on one or multiple patients. There's no limit to the services that we can provide in that situation. And it's not uncommon for providers to call more than once with those more complex cases or with those cases where a new medication has been started. Also with those complex cases, it may be that there's something going on both physiologic and psychologic that need to be addressed together. As mentioned earlier, Cpan is an adjunct to the provider's practice. If you are already enrolled in Cpan, you have already obtained information about our services. But if you've not, let me just share for just a moment here. To register for our services, it's really simple. All you need to do is either give us a call at 888-901-CPAN or email us, and we can go ahead and do that verbal registration right over the phone. Then when a provider would like assistance or referrals, they can call directly our number, 888-901-CPAN, same phone number, press 1 and then press 3. That gets us directly in contact with you. You will go ahead and speak with either Elizabeth or Wiley, or once in a while, I even answer the phone. We'll ask a few questions about the services that you're looking for and about the patient. And if your call requires a psychiatrist, we'll go ahead and get you connected with them. You can either ask to speak with them right away, and we'll get you in contact with that psychiatrist with less than 30 minutes, and our average turnaround time right now is about 8. Or we can have you decide on a time you'd like us to call you back. Sometimes there is a break in your day or at the end of the business day, and you would like to have our psychiatrist call you back at that time. We're available Monday through Friday, 8 to 5, excluding institutional holidays. So let me go ahead and then just finally put up the side here for the information on your getting your CME credit. One moment, please. All righty. So here is your QR code for your CME today. We appreciate you joining us, and I'm going to open up the phones for any other questions you have, either for Amber or for me related to the Texas Child Psychiatry Access Network, Cpan. So we have a few minutes here still left. What kind of questions do you have?